Russell. I lecture in anatomy at La Trobe University in Bendigo. Okay, let's take a closer look at the thoracic region. We're actually talking about what's bordered at the upper end by the first rib, the upper edge of the sternum, and the base of the neck vertebra at the back. Its upper aperture or entrance allows the trachea or air that's coming from the nose and mouth to travel down to the lungs, the esophagus to send food down through the diaphragm to the abdomen below, and nerves and blood vessels to travel to and from the head and neck. The inferior aperture, which has the diaphragm as a muscular border around it, is bounded on the front along the edges of the rib margins and on the back at T12 level. On full expiration, the dome that's created by the diaphragm can travel up as high as T4. It has two exit points also for the esophagus, as we've discussed already, down to supply the abdomen, and the inferior vena cava, which runs upwards from the liver back towards the heart, and behind the diaphragm against the wall or the vertebral column runs the aorta. Let's now take a quick look at the ribs. There's actually three different kinds of ribs. True ribs, like these, which have cartilage attaching straight onto the sternum. False ribs, which have cartilage that attaches onto the cartilage of other ribs and then onto the sternum. And finally, ribs 11 and 12, sometimes 10 as well, which are floating ribs and don't have cartilage that goes anywhere beyond the musculature in the posterior part of the thoracic cavity. Let's think about the muscles that are involved with the thoracic cavity. We generally think of the rear wall of the thoracic cavity as part of the back, and so we don't include the musculature there. Neither do we include the musculature that goes on to the upper arm. So the pectoral girdle in the front here is removed. Essentially, we're dealing with the muscles that sit between the ribs, or the intercostal muscles. And there are a few others that are involved in the process of breathing, but they're not part of this particular lecture. So the two muscles that we are concerned with are the external intercostals, which run from the rib above down to the rib below, from lateral to medial. Underneath those, you have the internal intercostals, which are actually running the other way. So from medial to lateral. Clearly, these muscles play a role in the process of the ribs separating and coming back together in inspiration-expiration, as we'll see at the end of this lecture. Let's quickly examine the surface anatomy. At the collarbone or the clavicle is the apex of each lung. Anteriorly, the lungs go down to around T5, T6 level, the same height that the apex of the heart is at. At the back, however, they go much further down to T11, T12. Obviously, on expiration, they'll be up around T4, T5, but on full inspiration, As the diaphragm moves downwards, so do the edges of the lungs to follow along with that. The left lung, because it has a notch for the heart taken out of it, obviously will be further across in the midline underneath the nipple. Moving on to the structure of the pleural cavities, you have a parietal layer of tissue and a visceral layer of tissue up against the lung itself, with a potential space in between. This is full of a fluid called surfactant in the case of the pleural cavities or around the lung. The pericardium has its own fluid around it, and in both cases the object of this fluid is to decrease the friction between the two layers of tissue as you're breathing in and out, or as the heart is beating. The right lung has 3 lobes and the left has 2. Let's take another look at this. What we're actually talking about is the membrane that runs around the outside edge of the lungs and hard up against the internal wall of the thoracic cavity. That's the parietal part of the pleural membranes. Then against the lung itself you have the visceral part of the pleural membrane. Between these two is a space, and that space is actually filled with fluid, which is a serous fluid, a bit like oil, and its job is to make sure that while you're breathing there is as little friction between the lungs and the wall of the chest, and for that matter up against the heart, which is in its own sac, as possible. As you can imagine, if those structures were actually sitting up against each other without this membrane in between, very soon you'd start wearing out the outer surfaces of both the lungs and the heart. Not a terribly desirable thing to do. Let's take a look at this from a slightly different view. Here we can clearly see the parietal layer of the pleural membrane. The visceral layer would sit against the outside of this particular lung tissue, or you can see it here quite clearly as it's been cut. The space in between is where you see the fluid, and in this case it's surfactant. It's a little bit like oil, and its job, very clearly, as I stated before, is to try and minimize the amount of friction between the two surfaces. It also keeps them nicely adhered to each other, so that as the lungs are expanding, the chest wall expands outwards, the lungs go along with them with surface tension between the two. If it helps, you can imagine this as a large balloon with oil poured inside it and tied off, and no air within the balloon. Now the two surfaces of the balloon can move quite freely without much friction against each other, and as you pull one layer of the balloon and try and pull it away from the other, you actually maintain the space between the two. You can't expand that because you've only got fluid on the inside. Same thing happens when the lungs expand. The chest wall goes out under muscular control, and as it's doing so, the lungs move out with it expanding. The diaphragm moves downwards, and as a result of that, the amount of space inside the thoracic cavity is increased, and this is what causes the lungs to expand. Against the back wall and the mediastinum, you can see the esophagus and the aorta, which are not the topic of this lecture. However, they are relevant when we consider the clinical advantage of having the chest or the thoracic cavity split into a number of areas. If we were to puncture the chest wall over here on the right hand side, this would result in the right lung being deflated, but because that sits within an entirely different set of pleural membranes to the left hand side, only the right lung deflates. Same happens in the case of a puncture to the left lung. What this does do is it potentially introduces bacteria or infection into the pleural cavity, and this would result in essentially a pleuritis. Now, because this is a nice moist warm environment and it doesn't have a terribly good blood supply in it, this is fairly rapidly a rather dangerous situation. Likewise, if the sternum was cut to access the heart and its pericardial sac, the pleural cavities are actually spared because they have a layer of tissue that separates them from the heart. The result of this is that hopefully infection, at least in the initial case, would stay solely within the region of the pericardium. Okay, let's just review what we've covered on the thoracic region. We started by looking at its upper limit, which is at T1 and the first rib, and we know that the trachea and the esophagus and also the nerves and blood vessels to and from the head and neck go through this upper aperture down into the thoracic cavity. From below, the thoracic cavity is separated from the abdominal cavity by the diaphragm. Again, the esophagus passes through it, as does the inferior vena cava, and the abdominal aorta goes down behind it. On its posterior side, it's at the level of T12. On the front, it goes around the edges of the rib cage, attaching to the cartilages from T7 up through 10, and onto the xiphisternum. True ribs attach by their own cartilage to the sternum, and they're ribs 1 to 7. False ribs have an indirect connection to the sternum via the cartilage of those upper ones, and that's rib 8 to 10. And then you have floating ribs, which have rudimentary cartilage only that stays within the abdominal musculature, does not at all reach the sternum, and those are ribs 11 and 12 and sometimes 10. The thoracic cavity is a typical body cavity. It has secretory membranes that set between the parietal and visceral layers, both of the pleura and the pericardium. As far as the musculature goes, the posterior wall is considered to be part of the back. The pectoral girdle is not included, and the muscles that we are concerned with are the external and internal intercostal muscles. The distinct compartments that are created by the pleural membranes have a clinical significance. They limit the spread of infection. They mean that trauma to the lungs on one side affects only that side. But due to it being a nice warm and moist environment with very little good blood supply in there, creates the perfect site for infection if either of those membranes is breached. Same thing happens with the heart, and this also allows during heart surgery where the sternum is cut to ensure that the pleural cavities are not affected unless there happens to be a cut into them. I hope you enjoyed the presentation.